Unintended myopic biometric error in posterior amorphous corneal dystrophy patient submitted to anterior segment Scheifele analysis. Early visual recovery and predictable refractive outcomes, minimizing the patient's dependence on glasses, are key goals of the modern phacoemulsification. Both the use of astigmatically neutral incisions and biometric accuracy are essential tools to reach that aim. Several biometric formulas can be employed for this purpose, all of them depending on the same preoperative variables. The most remarkable ones are central corneal power, usually measured by computerized keratometry, video keratoscopy, or by means of a Scheifele system. Axial length of the eye, obtained from immersion ultrasound biometry or from optical coherence interferometry. Postoperative refractive prediction is an absolutely relevant issue for the cataract surgeon. In a review of 168 cataract surgery malpractice claims in 1999, Brick found the largest group of identifiable claims was related to inaccurate IOL power, according to an ASCRS member survey conducted in 2003. Inappropriate lens power selection was the most common reason for IOL explantation or exchange. In this video, we present a case of a patient with posterior amorphous corneal dystrophy and cataract submitted to phacoemulsification and bifocal intraocular lens implantation. Preoperative biometric parameters were obtained from the Scheifele system and immersion ultrasound biometry. On a routine ophthalmic consultation, a 63-year-old woman complained of slowly progressive blurred vision and also some perception of halos and glare for both eyes. At slit lamp examination, both eyes showed increased corneal mid-stromal refringence, narrow anterior chamber angle, and nuclear sclerosis. No other abnormalities were detected. Cataract and posterior amorphous corneal dystrophy (PACD) were diagnosed. Scheifele anterior segment topographic study (PANACAM Oculus) was used to calculate central corneal power. Keratometric readings of 41 and 37.5 diopters were found for the right eye and for the left eye respectively. The eye's axial length was measured by immersion biometry, OcuScan, Alcon, and IOL power was calculated using SRKT biometric formula. Routine phacoemulsification and bifocal restore SN6AD3 intraocular lens implantation was planned for both eyes. She had an uneventful procedure for the right eye, but on the 7th postoperative day visit, the patient was unhappy with her near and distant uncorrected vision. No abnormalities were detected at slit lamp biomicroscopy, Scheifele topographic anterior segment analysis, and all biometric calculations were carefully rechecked. Again, the expected postoperative manifest refraction was different from the actual one. So, what happened? Is this refractive surprise supposed to happen again for the fellow eye? Then, an apparently irrelevant detail gave us a starting point to our investigation. The central keratometric readings, obtained from the computerized keratometer Humphrey instruments, were nearly 1 diopter steeper than those ones from PANACAM if applied on the SRKT formula. This new data input yields an IOL power calculation 1 diopter weaker than that IOL power previously selected. To further investigate the case, we decided to use another technology in an attempt to assess the actual anterior corneal curvature for both eyes. We decided to perform corneal topography based on Placido's disc's reflection, obtained from Orbscan 2, Boston 1. These keratometric readings showed close similarity with computerized keratometry, but again, showed remarkable difference from those ones from PANACAM. For the left eye, IOL power was recalculated using keratometric readings obtained from Orbscan 2 with immersion biometry. The IOL power was then reset at 24 diopters, 2 diopters weaker if compared to the power predicted by the PANACAM keratometric readings. The patient had an uneventful surgery for the left eye. On the 7th postoperative visit, the patient was happy with her near and distant uncorrected vision. A month later, the right eye undesired myopic refraction was addressed by photorefractive keratectomy enhancement. Her postoperative manifest refraction and uncorrected visual outcomes were similar for both eyes, and the patient became very happy. There is no documented explanation for such inaccurate measurements in patients with PACD. To your knowledge, This is the first documented case in the literature describing a central corneal curvature misreading by the Scheimpflug system with Benecam in a patient with BACD. In this case, keratometric measurements obtained from the Scheimpflug system led to postoperative refractive surprise once the measured central corneal power was flatter than they actually are. We theorized that the abnormal corneal transparency may have disrupted the Scheimpflug system from functioning properly, inducing an artifactual central corneal planation, and, as a result, leading to inaccurate IOL selection in these patients. Keratometric readings from computerized keratometer and also from Placido's discs are not influenced by diminished BACD's corneal transparency. They rely essentially on corneal reflection. Keratometric readings from computerized keratometer and also from Placido's discs are not influenced by diminished BACD's corneal transparency. They rely essentially on corneal reflection. Elementary functional principles of the different technologies employed for the analysis of the anterior segment of the eye, as well as the advantages and limitations of each one, must be clearly kept in mind by the cataract surgeon. The alternative use of technology not dependent on corneal transparency was capable, in this case, to provide more accurate and reliable data. Summarizing what we learned from this case, as described by Couvert et al., postoperative refraction of the first operated eye offers a valuable tool in terms of refractive prediction for the fellow eye. Among BACD patients, and possibly with any other diffuse corneal opacities, Scheimpflug readings must be used with caution for the IOL power calculations. And so, whenever new technologies arise, surgeons must be aware that new error sources may come along.